And then now it looks like we have a great representation from all over the state, and everyone, it looks like, thank you all for renaming yourself. You can click on those three dots and put your facility. It looks like most people have done that. And Natalie's going to take us away here.
Wonderful. All right. Hi, everyone. Good to see you all again. I hope you had a nice summer. I know we're all winding down here, but you maybe even faster than some of us farther south. So what we wanted to do today was really do a deep dive into what you've been working on over the last few months in terms of SDOH screening. And if you have done kind of a true PDSA cycle test of change, that's great. If you have not and are still in the thinking about doing something or exploring or wanting to throw ideas out before you even get started phase, that is perfectly fine too. We'll spend the first part of today sharing those perspectives on what you're working on, what you're learning, and doing some brainstorming as a group as needed. And then in the second half of today's session, as we have time, I have some more reflections and lessons and tips that we've heard as we've continued to work with other hospitals that I will share to prep us for the next round of PDSA. So maybe just as something fun, I think when we do the round robin, I'll have everybody introduce themselves. So we won't do a traditional icebreaker, but if you could drop in the chat, since we're transitioning from summer to fall, what is your favorite end of summer, early fall activity or tradition or thing you're looking forward to? I would love to see. Mine is college football, the beginning of college football season. I went to University of Michigan, so I am excited for that all to kick off this weekend. I talked through this already. Our goals for today, really first and foremost, are to hear from all of you. We'll do a round robin. And if you could just share what you're working on, or if you're not even working yet, what you're thinking about, or what you're anticipating working on. And then what did you learn? So what are the challenges you've encountered? What are things that worked really well? What are tips or feedback you'd offer to others on the line? And then in the second half of the conversation, as we have time, we'll talk about those ideas for what I'm calling refining the screening process. So we talked a lot last time about the nuts and bolts, the 5 whys, the basics of how do you pick a tool? How do you make sure there's a space in your EHR or otherwise to document the results? How do you pick the person or the team who's going to be asked the questions, those kind of basic first steps. And then the slides that I have today to talk through and share with the group are more about how do you refine that process to make sure you're creating a safe environment, a trusting environment, so that patients feel comfortable sharing their needs. And then how do you do something with those results going forward? Let's see, some fun. I'm going to read these later. State fair, bonfires, more college football, or regular football, professional football. Awesome. Fun. All right. Thank you, everyone, for sharing those. So just to frame before we get into the round robin, I shared this slide last time, but I think there are 2 elements of SDOH screening that I like to focus on when we have these conversations. And the first is that it's really building new muscles in a lot of ways, right? It's a new skill. It's a new set of questions that we're asking patients. For a lot of us, it's the first time we've asked these questions in a healthcare setting. And as patients, it's the first time we've been asked these questions, maybe ever, or especially in a healthcare setting. And so I think it's inevitable that we're going to realize there are processes or skills we don't have yet that we'll need to practice and build on. So if there are ways that you have felt your muscles strained or sore in this process, or challenges you've run into, please do share those with the group. Those are helpful for all of us to learn. And then the second piece is that I think of the SDOH screening as a new piece of the puzzle, right? The puzzle of how do you best care for the patient in front of you in the hospital and also your community as a whole. And so sometimes it can feel overwhelming or confusing to think, why are we adding these additional questions or this additional set of responsibilities to our team that already has a lot on their plate? And so I try to think of it in terms of how does this add new information that can help you achieve those best outcomes for the patient? So it might be a missing puzzle piece in terms of helping to understand how you can create a better discharge plan, or how you can help them transition to the next care setting more seamlessly. it may be that the puzzle piece for you in terms of SDOH screening is that it helps you see patterns in your community that you hadn't seen before. And so maybe there are changes to the way you deliver care or the way you partner with organizations based on that information. So think of it as an opportunity to add to a lot of what you already know about your patients, and offer a different perspective. So with that, let's jump in. So 3 simple questions. Just what are you working on related to SDOH screening? What have you been thinking about or doing over the last 8 weeks or so since we last met? And then what are you learning? So what's working well? What's not working well? I guess only 2 questions. What are you doing and what are you learning? That's the gist of it. We'll go around the group. Please chime in either verbally or with questions if you have, or verbally or in the chat if you have questions for one another. I'll also try to pause, but really want to just hear what's going on, and then we'll see what themes come out and how we can share. So we have a volunteer who wants to go first. Otherwise, I'll have to go in order. Is that a hand?
It looks like
Yeah,
Christine.
Kristen? Awesome.
Hi, can you hear me?
Yes.
Yep.
Awesome. So we have actually, I've been able to gather information. I wasn't sure how we were going to start addressing this. And so we reached out to our IT department. It looks like we're starting to move things into production, but it won't be live just yet. They are adding things to our admission assessment form, which will be completed by nursing. They're going to use that section for the G codes. So the G codes will generate that reimbursement, hopefully. They're doing it for both adults and peds. The last piece they have remaining to build is the rules to fire. And the rule will be firing tasks to the case management task list when nursing documents in that section. And we're on Cerner for those of you that don't know. We actually have about 9 EMRs, which we have a huge project undergoing to migrate everything to one EMR, but that probably won't happen for a few years. Some of the things that we are serving are going to be the personal characteristics of language. Are you most comfortable speaking? They have a migrant farm worker question on here. So I'm thinking that these are Cerner generated surveys. I'm not sure if that is altogether appropriate for our culture. Is that a good way to put it? We don't have a lot of farms in Fairbanks that need working. And so thinking about our folks that we serve, there are definitely some farms in Delta and that area. Maybe down towards Nenana, there are some bigger farms. And then if folks come up from the valley, if they're referred from the valley, maybe that would be appropriate. But that one makes me scratch my head. And this next question is very appropriate for our population. Have you been discharged from the armed forces? It gets into family and home. What's your housing situation? Are you worried about losing your housing? How many family members, including yourself, do you currently live with? Money and resources, highest level of schooling, current work situation. During past year, what was the total compensated income for you and your family members living with you? To me, some of these are very specific, and I'm worried. Just personally, I don't know what the best practice recommendation is, but thinking about myself as a family member or a patient, worried that people might be concerned about, are they asking this because they think I can't pay for my care? So I really hope in the future these questions become languaged a little differently. In the past year, have you or any family members you live with been unable to get any of the following items? And there are things like childcare, food, clothing, etc., medication. And there's a transportation question on here, which I think is great, especially since we serve such a large demographic. People come to us not only via car or bus or on foot, but they also come in from villages and remote communities via other methods, sometimes life flight, sometimes private airlines. So, and then social emotional health questions, which are pretty general and basic. So nothing out of the ordinary there, except are you a refugee? And I thought that that was interesting too, because I'm concerned that folks might hesitate to answer that question, even though there's I choose not to answer that question option. So I'm curious to see what other facilities are doing and what you all are doing on some of these questions that I have questions about surrounding safety in the question. Thank you for your time.
Thank you so much. That was a really helpful overview and lots of questions packed in there. Before I ask you some follow-up questions, does anyone on the line have questions for Christine or responses or experiences with the questions she raised, specifically around those questions about migrant farm workers or refugees, or some of those really specific personal questions? Anyone have thoughts or reactions to that?
Hey, Natalie, this is Deb Kelch from Bartlett. Chris, and I don't know, Chris, if we had talked about this on the phone last time we spoke, but what are you guys, did your organization just put these questions together themselves, or are you using a specific tool?
Yes, people in the chat had the same question, and you're right. It is the prepare tool. I tried to show you, but my camera is doing this blurry thing. So I put it in the chat. It is the prepare tool. So I'm wondering, who are the people who wrote these questions, and did they keep safety in mind? Right? Emotional safety or privacy.
Good
morning, everybody.
I'm sorry, go ahead.
I'm sorry. This is Sue from South Peninsula Hospital, and Meredith and I have been kind of looking at the Prepare tool, and we were going to maybe make some changes to it to fit more of our demographics here in Homer. But how far can we deviate from the questions? I'm wondering, as I'm hearing that people are using this tool, can we reformat it? Is that going to get us into trouble down the road when we have to do reporting?
I have the same question. Thank you, Sue.
Mm-hmm.
This is Jeanette at Bartlett, and I'm not going to probably answer your question exactly how you asked it, but we were using the Prepare tool originally and had built it into our EMR, and we're on Meditech. And, you know, when Deb brought forward the CMS tool, we switched over to that. And there are still a lot of questions on there that aren't required. So when we built that one into our EMR, we did it with the 5 required domains at the top, and those are kind of bolded. And then we put the other questions below so that it's more of, if there's time or if it seems specifically relevant to this patient, we can answer those questions as well. But to make sure that we're capturing what's mandated to be reported on, we just moved those 5 to the top.
I think that
I have a question.
Helpful. Thank you.
I agree, Sue. And I'm wondering if any of you on other facilities, has quality been the first stop for this building into the EMR, or have your IT departments jumped on board, done this to meet a requirement, or did they buzz by you as possible potential subject matter experts? Because I don't know if they did that. We've had a change in leadership. My previous leader could have been involved. I'm not sure. But I'm kind of scratching my head wondering, how come we didn't have the 3 best tools to pick from and had some consulting? So just wondering what the standard of practice is. Do these things just change? Based on my history, I'm not sure. Maybe these things just change and update in the software system that you subscribe to. For example, for us, it's Cerner, and these are just additions that get rolled out to a facility once you're bought in. Thoughts?
This is Helen and Manila. Quality here was the first ones to discover the new requirements. So we were the ones leading here. We are lucky that we're part of the THO with ANMC, and one of the other THOs took the Prepare form and made it more appropriate for us, and that has been shared throughout ANMC, the THOs that work with ANMC and have that Cerner access with them. So that's how we went about it.
I'm just curious to see as we implement this as our test of change and then in the coming year and get this live, even though it's in production mode, it sounds like behind the scenes, a lot of work is going into this. So I don't want to be the one to rain on the parade first thing out of the gate. Maybe what they've got works and it's a best practice tool. And maybe it'll work for our community, or maybe our registration folks or nursing will hear some other things and request a revision as we go. So it'll be interesting to see how we went on this and how many barriers we encounter. So I look forward to updating all of you.
Chris, can I ask you one more question on that before we move ahead? Do you know what the reaction has been from the nursing team who will be asking these questions?
They haven't seen it yet, and it's not live, and I would imagine that they will not necessarily get a preview. It will be just turned on and activated. But if quality is involved, it will be interesting to see if we can have an influence on, is this the live version, or is there an option for modification and input from the folks in the GIMBA? Great question.
Yeah, I think so. To answer your question, the CMS requirements in terms of reporting are only for 5 domains, and the questions are not. There's no specific tool required. So there is a CMS tool that you can use, but if there's a transportation question in the Prepare tool, housing, I'm not going to remember them all, but so there's no requirement to have all of those asked. I guess there's some flexibility from that CMS requirement standpoint. Same thing for Joint Commission. I know it's those 5 domains are required, but the specifics of which tool you use is left open. So from that perspective, I think there's certainly flexibility in terms of how you customize the tool to make sense for your patients and community. I'm going to talk a little bit later too. One of the things we hear a lot is how important and how helpful it can be to actually ask patients in advance about the tool. Like if you have a patient family advisory council, or have a way that you can have some kind of listening session, or even just, run the tool by a couple patients or family members who might be willing to offer their perspective on, oh yeah, that would not sit well with me, or it would be really helpful if you could ask it this way. So if there's an opportunity for you to think about partnering to do some of that testing or getting feedback proactively, it might help the rollout.
Absolutely. Heart of the patient is super important, and we preach it here, but we don't always remember. We get so excited about starting new things. We don't always remember to pause and collect that feedback. Thank you for the remander.
Yeah.
No, it looks like Eric. Oh, okay.
Yeah, good morning. So Eric Boltes from Search down here in Juneau. So yeah, for our department, we're both, quality and compliance. So we kind of came at it from both directions with from Joint Commission standards, and then looking at the quality side. And we have a great advocate in Dr. Bewley, who's our VP of our primary care clinic. So it's actually our primary care clinics that are kind of leading the drive. And I don't know if Helen is using our form, but we did submit a form through ANMC. It's an ad hoc form based on the Prepare form that we've modified. And we're looking at most likely doing that through a tablet and having the patient just in the, in the waiting room filling out those questions, because, some of those questions are very private and personal, and talking to them about the confidentiality of that information. That we hold that close, and that form will also generate Z codes. So then the provider, when the patient gets back to the clinic space, the provider can pull that up and they can see those Z codes that are automatically charted, and then they can add notes, and then it keeps a history over time. If they fill that again the following year, it has those different codes, and it can give a little bit of a history and where they're at currently. So that's where we're at. We're just kind of right to that point. We haven't rolled anything out yet, but we're getting very close. And Bettina is also online. She's one of my PI managers. It's helping to head up this endeavor.
So Eric, hi, this is Jeanette at Bartlett, and we really want to do that as well. We feel like we'll get a lot more authentic answers, and also not every patient, you know, a lot of the patients can do it themselves and don't need to have that questions asked. But
Yeah.
do you have that form built already that will automatically go into the EMR?
It is, yeah, it's built in Cerner. Yeah.
That would be really interesting. That's what we're trying to figure out with Meditech, if we can get it, something like that built that would go right into their record.
Yeah, it's nice to have that automatically. And then what Dr. Bewley and a few others did, they did all the mapping in the background. So if this question one, ties to transportation, and that they answer it, depending on what level of transportation their need is, and then that reflects to the corresponding Z code. So it's a lot of background coding work as well.
Great, thank you.
Thanks for sharing that. That's excellent to set it up that way so that you can pull the data out. And it's not just going into a black box. Have you rolled this out already with patients? I'm curious what kind of response you've gotten from the tablet, if you feel like you've gotten a higher response rate, or if patients have offered feedback on how that's working.
Yeah, I haven't rolled it out yet, so we're just right about there.
Great. All right, Meredith.
Sorry about that. So I and Sue and I have just really started looking at this. So we're kind of probably a lot further behind than everybody else. And we use Evident or Thrive as our EMR, but we have a potential, or I guess really a planned migration over to Epic. So last week I did send, the information and the Z code. We talked with our billing group to see how familiar we are with Z codes so far, what's already there. And then informatics is also kind of generating a report for us so that we know what Z codes are being used. And then I also provided the Epic presentations so that informatics can kind of, let's see how smooth of a transition that we can get going there. And then, as Sue mentioned, we were kind of looking at this, so I'll be glad to go look at the CMS, the 5 domains, and kind of see where we are. But my initial concerns were, yeah, this is a lot of really private information. Who's going to be asking that? That tablet idea is great. And then for like migrant farm workers, we have quite a bit of summertime farming going on up here, but then also the fishermen that go out and maybe just come up for season and then they're here. So that would be, in my mind, kind of falling under that migrant worker sort of. Wondered if anybody else had thought of that or brainstormed about fishing. Yeah, I think for the most part, that's kind of where we are. We're just really at that early stages of data collection. And then also trying to loop in the map, the community assessment program that occurs here, to see really what kind of resources are going to be available. My sister happens to be a nurse too. She's a case manager at a large hospital in the lower 48. So, they're knee deep in trying to do this. She said that from her perspective, the most feedback that they've gotten out is they've identified a lot of holes where patients have said, yeah, we need resources, and then there are no resources to fill it. So that's one of the things that I'm concerned about here in tiny little Homer, where somebody says, yeah, I really need some assistance with this. And has anybody else thought about that, or thought about how they're going to plug the hole that when we say, oh yeah, I need help with this, and what if we don't have the resources handy and nearby? So, and just the the vulnerability of the things that we're asking about, and how that's going to be affected by everybody.
Hi, Meredith. I know that's kind of a tricky thing to say. Do we want to ask if we can't help? But I think, there's been discussion about it, and I think it's really important to capture that information, and then we're able to demonstrate those holes as well. So whether that's on a community level or a hospital level, I think if there are things that people need, and we document that we're searching every option in the community and it's not available, that's the situation. But I think it's really important to be able to capture that, and that's the information you can take back and say, we're seeing this with this many patients, and it's a real barrier. And then the other thing that's really nice is if we're capturing our Z codes, and you're able to then, kind of look at Z codes and specific diagnoses, where they cross over. That's also going to really say, this is how this is impacting, health conditions. So getting the information is super important. And then we can kind of build the resources that are lacking from there. That's my view on it anyhow.
Yeah. And I guess my other thing that certainly I would be happy to hear offline or through some other way, since we're just now starting to look at this in depth, is there anything that you guys did just recommendation wise to start, or that you wish you had known when you first started looking at your processes or what you were going to do? I wish we had known this before now, if that makes sense.
Tina, do you want to speak up?
Yeah, so I'm Bettina from Search. I'm one of the PI managers. I work with Eric. And one of the helpful resources that we used or created is a resource, a OneNote page full of resources by community. So if there's a transportation issue in Haines, well, we can present that resource at the time of the patient's visit and let them know these are the resources available to you for transportation or housing or food. And it's a really neat tool that we've created, and it's can be found across the consortium. So
thanks for sharing that.
Mm-hmm.
Any other what I wish I knew, what I wish I had known pieces of feedback for Meredith? All right, let's keep going with the round robin then.
Chris,
Debbie, can you help me unless we get a volunteer?
I was going to say, Chris kind of followed up to what Bettina said in the chat. Work as a state to add to that tool and share it among hospitals. Is that, Chris, are you talking about what Bettina shared?
Yes, I'm wondering if since they're working as they find things in the state that will help people there in their community where they're sharing, even if it's a bit outside of the community. We're such a big state. Sometimes I'm wondering we might trip on different pearls or different treasures or different small pockets of resource. I wonder if we were to be able to share those on a list somewhere statewide, maybe on the AHA website or somewhere that we all knew that we could tap into that are not community specific. So only offered to Fairbanks North Star Borough residents, but maybe offered to residents throughout the state, but it's available located here in Fairbanks, but other people can tap into it. Maybe that would be something good to throw on the list that Bettina's working on if she's finding that there are resources outside of her immediate area that might benefit folks throughout the state trying to meet other people's needs. And maybe this becomes a statewide improvement to help close some of those gaps.
Natalie, have you seen other communities work on that together, something like that?
I don't know that we have heard of hospitals working statewide to do that. I think it's a great idea. I know there are other states who have implemented like 211 systems, phone line systems, where people can call in and there's a phone line that has community resources. So it sounds like it would be something in that, along that same vein of trying to compile resources across the state that then you could share out. So I think that's a great idea.
And maybe amongst this group, if Bettina, if you can share that with us, and maybe others, if you put something together, we could try and, at least as a group, right now, we have 9 facilities, 9 facilities from the state on the call today, which is amazing. Great, from all over. So maybe Krista and I can talk about that after the call and see what we can do to work with each of you on if you're putting something like that together and kind of compile it and have it on our website or have it somewhere. So that's definitely something I want to follow up on.
Great.
There was someone else had a hand up earlier. Did someone else have something before we moved on? There's some great comments in the chat as well.
I think it was Christine and she put it in the chat. So
okay. So I think a lot of folks have shared actually already. Natalie, do you want to just see if someone else has something more they want to share? It seems like
Jesse, I see your comments in the chat about community health workers and other resources. Do you want to share anything more about that or experiences you've had of working with community health workers? Could you say a little more?
Sure. So I'm new to the group. Sorry, I'm actually not representing a hospital, but I work with the state of Alaska section of chronic disease prevention. I think I got forwarded this because I'm also doing work on SDOH, screenings and referrals for treatments and follow-up. And we are about 4 months into go live with a pilot project that we did with an FQHC located in the Upper Sioux region of the state. Where we brought in a third-party vendor. We worked with the FQHC to implement the Prepare form, which is a tool they elected to use because it was pre-built into their EMR. They deliver the Prepare form via text message. It goes out to the patient. They can fill it out on their own personal device at home, or if they haven't done it yet, they can do it on an iPad in the clinic. And they do it at new patient and then once annually. Based on the data from the Prepare form, we then set up an automated e-referral through this third-party vendor over to Connect Mat-Su. So all patients who identify as having an SDOH need are then referred over to Connect Mat-Su directly from the EMR, who then reaches out to address their SDOH needs with them. And then in addition to that project, we went ahead and piggybacked on the Alaska Tobacco Quit Line too while we were at it, because it's a great resource. E-referrals have been proven before with them. So every single person, they do an opt-out and an opt-in model, 2 different models, but everybody who screens positive for smoking, everyone is referred over to the Alaska Tobacco Quit Line through they have a quit manager that does some pre-screenings and then sends them over to the quit line. For SDOH, only patients who elect to be referred are referred over. So they have an opt-in and then an opt-out for the tobacco program. It's been running since May. It went live. It took, well over a year of foundational work to get it started. So it was a big project to get rolling. But it went live in May and it has been immensely successful in this community. And it really addressed a lot of the concerns. We don't have a resource to send someone to. Should we still ask the question? Well, yes, because it allows us to identify gaps in resources and we can start doing some work around it. Patients are cranky because they don't want to get called, for tobacco. They're happy smoking, what have you. Well, it turns out the number that called and complained was significantly less than the number who initiated a quit attempt because of the referral. It's been a great project and really pretty successful. And so now we're starting to look around and say, what else is happening? How can we, replicate this success or build on additional work or partner? And one of the things that came up was that the SDOH referral works because Connect Mat-Su exists. So what do we do in communities that don't have Connect Mat-Su? And that's where the CHW conversation came in. That we can work with FQs to do SDOH screenings, and then that screening generates a community health worker referral, and the community health worker then is able to address the SDOH needs in the community. So it's still early days on that piece, but it was a solution that we kind of worked to come up with around the fact that this amazing Connect Mat-Su just doesn't exist everywhere. So.
Thanks for sharing that. That sounds like a great program. It sounds like too the fact that you have the handoff to Connect Mat-Su, and then also someone from that team reaches out, right? And so it's I don't know if you want to call it a warm handoff or extra warm handoff and a hug to really continue the conversation seems to be something that's really important. Bruce, I see your hand.
Yeah, Jesse, I just have real quick questions. One of the things we've learned is that even when you identify a need, and even when your resources are available, patients many times don't want to do that. What's been your success rate for people opting in when a social need has been identified?
Yeah, so we originally kicked off the project with an opt-out for SDOH also, and that ended up kicking the unhappy can, if you will, down the road to Connect Matsu, who then got the calls. People were upset. I didn't want my needs addressed, blah, 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 blah. So we moved it back up and we put the opt-out at the clinic side where they could pick to go in and go out. And it did significantly cut down on the number of SDOH referrals that were made, but increased on the quality of the referrals. So folks who were referred over actually wanted their needs to be addressed or felt that they had a need that could be addressed. And so those patients were ready to be worked with at the time that the referral was made, versus when everybody went over, there were just some folks who said they have food insecurity, but they don't want anything done about it. So it
And
changed.
do you know the rates of the opt-out rates that were there?
I would have to pull the data for you. We're only a couple of months in, but I think we're a little bit over 60% opt out of being referred, about 40% opt in. So it's not as high as it was. And then the other thing that the clinic did was when they saw this change, they started working with their patient navigators who kind of see the patients, kind of help if they haven't done the prepare form yet, they help them kind of navigate through it, do a little bit of that in-clinic patient navigation. And every time a patient says, no, I don't want to be seen, they actually sit down with that patient and say, just want to chat with you about this project we're doing. Here's some things to know. Your data is confidential, kind of all the conversations. And they just rolled that out in June, but have been successful to convert a handful of opt-outs into opt-ins.
And Jeanette, did you have something you were going to say earlier?
I was going to ask Jesse if the tool that the patient fills out or the person fills out flows into their medical record.
It does. It goes straight into the EHR, and then we have an outcomes report that comes from Connect Matsu that also goes back into the EHR. That goes as a note. So if the patient is looking for housing and they're placed at X, Y, and Z place, that outcomes report then goes into a note, and the provider can see it the next time they see the patient and see that they were housed or what have you need was met.
What EHR is it? Do you know?
It is Athena.
Athena. All right, that's kind of where we're at, is we're trying to figure out how can we get this to flow into their actual medical record. And then I think maybe it was Eric who talked about it, getting those Z codes is great, but then, yeah, you have to have a provider, either a social worker, a nurse, or a clinician, physician, go in and document to those Z codes, which is fine. But yeah, just anyone who has any kind of IT connections that I could link up our folks with would be great, because we're struggling there, and it doesn't seem like it should be that hard.
Yeah, we're using a third-party contractor that we're hosting at the state level that we're paying for, but it's working directly with this site. And likely a successful expanded model would be to move that contractor over to another statewide organization so that smaller clinical sites could still have access to that particular contract to do the work that they need. But I'm happy to share the name of the contractor and any other resources we have. Obviously, as the state, I cannot recommend you do or do not use this particular vendor. It's just the vendor that we went with. But I'm happy to share their information if you'd like it.
Great.
And sometimes AHA has been able to have a group contract for something, so it actually reduces the cost for everyone because we're such small communities. So maybe that's something we can look into as well.
Well, Debbie, that would be fantastic. I think I didn't talk specifically on about where we're at. I mean, we've built the tool. We've done actually quite a lot, but we're still really struggling with how we're going to get the data captured. Nursing, we talked a little bit with nursing. They're not, it wasn't fully embraced. I've been trying to have the social worker case managers do it, and that there's an ebb and flow with that based on staffing, and we're really short staffed right now, and so it's not at the top of their priority list when they're trying to move patients along the continuum. And it's not to say that they're not assessing for those sorts of needs. They're just not asking those questions in that way and getting it documented into that tool, which is, you know, that is a bit more to add. And so we're trying to figure out, and the other challenge, what we're learning is that, you know, we kind of try to talk about multiple people being able to answer those questions, but then it goes back to, well, if, you know, 3 or 4 different people could get those answered, then probably nobody's going to get it answered because it's not specifically assigned to one group. So we are definitely struggling with figuring out how to get the actual tool routinely utilized.
Yeah, can I just pipe in there too, follow up there, Jeanette? I know there was a question out there. I can't remember who asked it, just as far as like, you know, any advice as they're diving into and really looking at implementing a tool now. I have to say, in retrospect, I think, you know, we got in there, we implemented the health related social needs screening tool. We have a report ready to go. I mean, we were on top of all of the, I guess the infrastructure for collecting this data, but and we kind of had a general idea how we were going to handle the voluntary year here. And I think just maybe really putting some thought into the data collection, the actual data collection piece as well would be really good, as far as, you know, like, cause, and I've been reading too with other hospitals, like, you know, you just cannot rely on the one group like case management or nursing to do the data collecting, right? Because it's like Jeanette said, there's going to be ebbs and flows. You know, for me, looking in like with our inpatient hospital, it seems really practical that we would have the patients fill out the information as much as possible. I mean, the actual tool is designed to be answered by the patient, not interview style. So I would really highly recommend those that haven't even implemented a tool yet to really look at that piece, and if they can have it where you're not relying on staff members to be asking these questions, because, you know, again, the staff are already looking at, you know, when there's obvious needs, we are addressing them for sure, right? But just in order to be able to submit this information to CMS, I just feel like, yeah, it just really focus on how you're going to collect the data as you're starting out. It's not like we didn't talk about it, but, you know, it was, I guess we're just thinking there was only going to be a few routes that we could go. But I'm excited to have that resource as far as from the state there. That's going to be great. And just to mention that CMS is now the homeless or unsheltered, unspecified, unsheltered, and unsheltered Z codes are now CCs. So there's going to be some reimbursement for those. So also focus in on how to capture the Z codes as you're collecting the data.
Great tips. Thank you. Chris?
I'm just wondering, oh, I should lower my hand. I'm just wondering if any of the folks who are going to be doing it without interviewing the patient, I'm with you, Debbie. I think this form is designed to be more privately interacted with. However, how could we be guaranteed that this isn't just us collecting information and clicking a box? How can we know that as our care teams are providing care throughout the continuum of care, whether it be lab or X-ray imaging, so testing, diagnostic work, and then throughout their length of stay, everyone who interacts with them, nutritionists, nursing, physicians, specialty physicians, how do we know everyone's going to understand the voice of the patient? Just because one nurse even does the interview, how do we really get everyone engaged in this form is important. We need to touch it. We need to read it. And as we plan and provide care for our patient and have those teaching moments or even those care moments, that we understand where this patient is really coming from. And we take time to follow up on, has anyone talked to you about how you're going to get your supplements now that you've had your tube placed? Have we got a gap here? Do you understand how to order these things? You know, there's so many options on this form that we could now be acknowledging that problems exist and not addressing them at each step along the care pathway. That's my concern. Anybody got great advice?
I think that's the question, right? That's the big question. What do we actually do with the information as you described across the care continuum? And there's a technology challenge, right? Is the information shared with all those different folks, and knowledge? Are people, do they even know it exists? And then how to actually use it. So I think, you know what, why don't we put that as we're going to try to think about that for next time we reconvene and start with that question of what are you learning in terms of Azure. It seems like a lot of people are on the cusp of implementing and starting to ask these questions. So would love to hear when we reconvene folks' reaction to that very question. It's a great one. I know we're already, we got about 14 minutes left. Are there any other questions or ideas the group wants to exchange? Otherwise, I have just a few slides that are kind of some resources to offer. And again, some kind of hopefully thought-provoking pieces as you move into the second phase of a test of change or implementation. I see, yeah, Bruce.
I have a question for folks. For those of you that are developing or implementing systems to get information, what are you doing with the people who actually see that information and training them on following up or talking to the person? So even if they use a pad, even if they use a form, wherever, somebody has to address that result. And I'm wondering if you're training folks, if you're scripting folks, if there's any part of work that you're doing in that piece of the puzzle.
I can just say the clinic that's doing the project for us implemented a really big education program for all their staff at every level to make sure that everybody felt really equipped before we rolled out the project.
Great. Anybody else? Yeah, that's great. I mean, one of the things that we're hearing and seeing is shame and stigma are part of all of this, and to respond to somebody's checkbox or wherever it is requires sensitivity to that shame and stigma that goes on, and that will affect, I think, what we talked with Jesse, how many people are actually going to accept services. The big reason they don't want to accept services is because there's shame and stigma associated with it, and that may even start with how you respond to a pad check mark. So I think that's one of the things to think about. If there's lessons, Jesse, you can teach us about how effectively that's done, tips and techniques on what people did to make that education great so that you could spread it around the rest of the participants, that'd be fantastic.
Yeah, so Bruce teed this up perfectly. These are, and we heard a lot about this today, the question of how do you actually do the screening? How do you actually ask the questions and have those conversations with patients? A couple themes have come up as we've talked with folks all across the country. One is, how do you explain why and what you're doing to your team, to your leaders, to quality, to IT, to nursing, to all the people that are involved in the process? How do you make sure people understand what's going on and why it's going on and how it can be beneficial? Second is, how do you explain to patients, right? How do you make sure patients feel comfortable answering questions and understand why you're asking and what you'll do with the information? This is huge. As Bruce referenced, there can be a lot of stigma and shame, particularly in small communities, or just confusion or hesitancy around why should I answer these questions? Related to that is the question of how do you build that trusting environment and make sure patients feel like they should answer the questions in a way that reflects their true situation. We've heard a lot from patients that we've worked with that they can feel like, well, if I'm asked these questions but nothing happens, why would I answer again honestly? And so I think it gets to that, not to say we shouldn't ask the questions, but just that there needs to be a thoughtful way of responding and following up and having a conversation, even if the perfect resource doesn't exist. And then finally, we hear a lot about how do you begin to build those relationships with outside providers, whether they're community-based organizations or social service organizations or others. How do you start to expand that network that you can refer and partner with to address needs? I'm going to share I'll share these links after the conversation today, but there were two interesting articles that came out over the last week, both in JAMA, I think, that get at a lot of what we've talked about today in terms of all of this sounds well and good, but when you get down into the details of implementation and actually having these conversations, we need to be really thoughtful in terms of how we're doing this. And there could actually be unintentional harm that comes if we don't think this through and really plan out how we're asking these questions and then following up. So there are a couple points in this article I wanted to just mention. And again, I'll share the link with you. It's really short and I think a helpful read. First, the authors emphasize that we should screen for social need, not just social risk, and need meaning the patient desires assistance. So Jesse, your comments were just perfect, perfectly in line with this article, and was something I hadn't thought about a lot until earlier this week. So your description of how you thought about that, anticipated that, and then set up a process so people could opt out, and then that ultimately improved the quality of the referrals and the services overall was just really, really helpful point. The second point in this article that really stood out to me was that the authors reflected on their own experience in a pediatric setting and noted that especially a lot of patients can feel ashamed or worried about being judged when they're asked these questions, especially patients who are minoritized or low income. And so we have to have, again, this awareness of how are the people, the patients, the families, the parents who are asking to respond to these questions, how are they experiencing it? How are they feeling? Are they worried about being discriminated against or having child services called? And making sure we respect parents' autonomy and dignity, and then working with those trusted partners in the community who can actually be the right messengers and support. The second article gets at that question of who are the trusted, they call them trusted local entry points, and thinking about our role as hospitals might be in doing these screenings, but then how do we really partner with the right folks in the community who are those trusted organizations who can have probably the best effect in terms of actually connecting with patients to improve health. So there are a couple of takeaways or recommendations in this piece as well that I thought were helpful. The first was a call to incentivize health systems to actually assist patients with their health-related social needs. So I know there's a worry that hospitals are only required to screen, and some think that that means hospitals will only screen and not do anything. I can tell you every hospital I've ever talked with, the first thing they say is, well, what are we going to do about it? So I think that, I think that worry is a little bit unfounded. We know that folks in hospitals know that they want to do the best by their patients, though sometimes those resources don't exist. The second was, again, about that theme of moving away from social risk screening and towards social need. And then ensuring that the folks who are doing the screenings have ongoing training. So this piece called for anti-racist and cultural humility training. That could be a piece, I think, general training, again, on why are we doing this? How can it help our patients? How can it help us as a care team? As well as a call to co-design these programs and these improvements that might result to meet these needs in partnership with patients and staff and community members. So these were a couple ideas I wanted to throw out to the group as kind of a implementation 2.0 framework as you're thinking about digging into the details and you're refining your process around screening. Here are a couple ideas. You certainly don't have to choose one of these, but I'll just go through a resource on one of these to wrap up today. So the first is engaging patients or community members in some way as you're standing up your process. The second would be really doubling down on figuring out specific strategies that you can use to build trust and create that trusting environment as you're having these conversations with patients. The third would be to test your assumptions. So once you've tested this out a few times with patients, maybe gotten some feedback, I have a suggestion for how to flip it around and see if you get some different answers or responses from a different perspective. And then finally, build a new relationship. So think about ways to reach out to maybe folks in the community you haven't talked to yet. So this framework is from PFCC Partners, which is an organization focused on patient and family engagement. If you haven't visited their website or seen their tools yet, they are amazing at the work that they do and have really specific strategies and tools for how to work with patients and families. I don't know that I have to convince this group, but this is a really great slide that I think talks about the power of partnering with patients and families as you're designing really any kind of program, but especially SDOH screening programs. So on the slide here, again, we'll send these around, are a couple ideas that we developed in partnership with patients on how specifically you could work with patients as you're building out this process. I'm going to go fast because I know we only have 4 minutes. The next resource on creating trust or thinking about how you can tweak your process to really build that trusting environment is a course that we actually just released here at Cynosure last week. It's a short mini course on exactly that topic. How do you create trust in the SDOH screening? And this has some lessons learned from hospitals that we've worked with over the past year or so. It has an interview with a patient and also an interview with a medical assistant at a small hospital in Colorado who has some really great insight on how to do this. This is another tool. I know I talked with Debbie and Chris about the interviews that you had done in the past related to readmissions. So I know there might be some history there. It sounds like perhaps there were some barriers to doing interviews. This is another tool that really helps to uncover that patient perspective. So this tool was designed by patient and family partners as a way to understand more about why a patient was readmitted. But I have a hunch, I think our team has a hunch that in doing some of these interviews with patients, we might hear about social drivers of health or health-related social needs that contributed to readmissions. So this could be another way of connecting with patients to understand the impact of those drivers in their life. And then finally, the final point about connecting with partners or others in your community, I think there is a lot of challenge here, but also a lot of opportunity, right? This is a chance for us to say, we see these needs, we have the data to show it, and how can we move forward together and in partnership to bring new resources to the community or to build on what we already have. So I think there's some chatter in the chat about the final or the next session. We're planning to meet again in October, and the charge is the same for the group as it was last time. Go forth and do a second PDSA cycle or continue with your implementation. It was wonderful to hear about all you've already accomplished already and the lessons that you shared. I learned a ton. So please pick another element of your process to work on, keep going, and then we'll reconvene in October. And our plan for October is to do another kind of sharing like this to share those lessons and learnings around, and then also to focus on the data, right? So now we have data, what are we going to do with it? And I jotted down a lot of ideas and comments from today about folks who seem to have really thought about that up front in terms of documenting the data and linking to the Z codes, which is excellent. So that's it for today. Thank you so much for your engagement and sharing. This was really, really wonderful, and we look forward to seeing you in a few months.
Thanks, Natalie. Thanks to everyone. And if you have some resources like Search has put together, we're going to talk about putting up like SDOH, like resources from all the communities, and get that in one place for everyone. And you'll see, we'll update the website with all the links and all the things Natalie shared today, so you can look at that in the next day or so, and you'll see an invite for October. So it's been wonderful hearing from you all, and glad you could all join, and have a good rest of your day.
Thanks, everyone.
Oh, let me stop the recording. There we go.